Good afternoon, everyone. We have a lot of participants that are flowing into the meeting right now. Thank you all so incredibly much for joining us. We are already at approximately 75 participants. So yeah, thanks so much to everyone for taking some time this afternoon to join us to discuss some really important content. And so as we continue to have those participants flow in, I would like to go ahead and introduce myself to everyone. Number one, first, thank you all so incredibly much for joining us for today's second of 3 statewide sessions that we are hosting as a part of the CalAIM Links program. Today, we're going to cover content specifically pertaining to preparing for contracting with managed care plans. My name is Alexis Taylor. I'll be one of your facilitators today. I'm a senior program manager here at HealthBegins, and at HealthBegins, we are a national mission-driven consulting and training firm, and it's our goal to help healthcare and community partners improve the social and structural drivers of health equity for both patients and communities. And if we go to the next slide, I want to let everyone know that today's session is being recorded. So you should have received a prompt once you joined today's meeting to let you know that we are going to be recording this session. All right, and so as we move into our welcome and housekeeping, we'd like everyone to take a moment to update their Zoom names. We really want to have a dynamic session in which we foster bi-directional communication. Although we're going to be presenting a very important curriculum today, we want to make sure that we can put a, face to a name or a face to, a picture and, know which organizations that you're representing. So go ahead and update your Zoom names, add your pronouns and the organization that you represent. And then second, we're going to have an icebreaker question. We want to set the tone for this conversation by just getting a little bit of insight on your level of comfortability with CalAIM. So using the chat, if you could all please go ahead. Let's see here. All right, I'm going to go ahead and drop a check-in question for you. And the question is, please let us know how comfortable you are with CalAIM contracting. And we have a few options for you. And so first you can see, are you new to CalAIM and just CalAIM curious? Are you someone that has some basic knowledge, or do you have a solid background? Or lastly, are you an expert and you're just here to support and uplift, knowledge sharing and really share some best practices with us? So go ahead and take a second to go ahead and provide us with your feedback in the chat right now. Great, we have, I love the emojis coming through. Thank you all so much. This is some great level setting for us, so that way we can understand where everyone is. And if you can, go ahead and just use an emoji, that would be super fantastic. And so to ensure that we can process the content that's being delivered today, we want to ask that everyone remain on mute. However, like I said, we want to have a very dynamic session in which we are fostering that bidirectional communication. So we are strongly encouraging everyone to use the chat. Please feel more than free to ask as many questions as you have. It is incredibly important for us that you walk away with a comprehensive understanding of the modules that are being presented. So after each section, we're going to have a knowledge check, so that way we can uplift any questions that you may have. But please feel more than free to go ahead and use the chat to ask those questions. And when we get to those Q&As, we'll go ahead and uplift those questions. And you can also use the raise hand function, so that way we can call on you, so that way you can present us with any question that you may have. Moving into the next slide, we want to present a very special thank you to our project partners. CalAIM Links is a collaboration of Transform Health, Aurrera Health Group, who led the design of today's content, and HealthBegins, the organization that I work for. And we are generously being funded by the California Healthcare Foundation. And if you want to learn more about any of our project partners, we are going to link the materials to today's session in the chat for you, so that way you can follow along using those materials. And you'll see in that deck that we also have hyperlinks to each one of the organizations that we work with, so that way you can learn more about our partners. Most importantly, and very excitedly, I'm super excited to introduce you all to Carlina Hansen from the California Healthcare Foundation. She has invested a tremendous amount of wealth, knowledge, and resources to making this project possible. So I'd like to invite Carlina to unmute and introduce herself to learn more about her as a program officer at CHCF.
Thank you so much, Alexis. Greetings, everybody. I want to thank you so much for joining today. I thought as we kick off the session, I'd share just a little bit about the California Healthcare Foundation and why we're funding this important work. If you hear a dog barking in the background, it's because my puppy is exuberant about CalAIM and excited to listen to the content as well. We know that 1 in 3 Californians lives in or near poverty. Because Californians with low incomes face the biggest health burden and the greatest barriers to care, our priority at the foundation is to make sure that they have access to high quality care. We also know that income is not the only factor that limits access to healthcare in California. Too many Californians face structural barriers to care based on the color of their skin, their ethnic background, or the language they speak. For this reason, health equity is the primary lens through which we focus our work at the foundation. We probably, most of us know that Medi-Cal is the predominant system of care for people with low incomes, and many people of color in California. And as Medi-Cal, through CalAIM, seeks to reach people in new and innovative ways, it involves a lot of exciting new partnerships. Partnerships that rely on community-based organizations who are deeply connected to the people that we seek to serve. And I know that there are a lot of you in the room today. You offer not only new services like those that are articulated in CalAIM, but new perspectives, and you provide an important bridge between healthcare systems and California's diverse communities. So we hope that by way of this important project, CalAIM Links, we can strengthen the connections between Medi-Cal managed care plans and CBOs in California. And we feel this is an important part of the puzzle to help us realize better health for all Californians. Before I pass it back to the fabulous team, I want to express my gratitude to HealthBegins, Aurrera Health Group, Transform Health. Their vision and commitment to health equity have made this work possible. A big special thanks to Alexis, who's leading the session today. So thank you all for your partnership, and to all of you attending today for the work that you do to improve the health of Californians. With that, I'll turn it back to you, Alexis.
Thank you so incredibly much, Carlina. And it was actually very pleasant to hear Kimchi barking in the background. And so we definitely want to just remind the entire audience that we appreciate CHCF's support in bringing this important work, to providers across the entire state. And for those that did not participate in the first statewide session, we've already linked those documents in the chat for you. We provided them via email. So if for any reason you did not receive those beforehand, you can definitely review those in the chat whenever you have a time to review that first statewide session. And so at a high level, we all understand that CalAIM is transforming Medi-Cal, by providing more equitable and coordinated services. And this provides an opportunity for CBOs and MCPs to work together. However, we realize HealthBegins, Aurrera Health, CHCF, Transform Health, we realize that smaller CBOs, particularly those that are BIPIC plus letter serving or those that employ a community-based workforce, they're going to encounter challenges when seeking those contracts with plans because they don't have pre-existing relationships. And the landscape infrastructure was just previously not set up to advance that type of partnership development. And so because we understand that equity-oriented partnerships, more importantly, strong equity-oriented partnerships between CBOs and between plans are critical to the success of CalAIM, CHCF funded our work to design this intervention and to advance those relationships between CBOs and MCPs and to advance their contracting readiness. And so if we go to the next slide, I'll be able to provide some background on the work that we did in 2021. Everyone should have received a link to the information session that outlines this content, but just to give everyone a 30-second recap so that way we can have some level setting. In 2021, we worked with HealthNet, Partnership Health, and the Health Plan of San Joaquin to host 9 technical assistance sessions. And those sessions focused on improving CBO contracting readiness and advancing that relationship building that I just referenced. In total, we had approximately 769 participants join those sessions, and the response was incredibly positive from our independent evaluator who evaluated that program. Huge thanks to Beth Siegel, who's on the line from Mount Auburn Associates right now. We learned that there were huge gaps in contracting readiness between CBOs, somewhere at very, early stages of contracting readiness, whereas there were others that were further along in the process and needed more tailored county-specific work. And so as a result of that, if we go to the next slide, we were able to improve and enhance the offerings that we had from the previous program design. And so taking those lessons and with continued support from CHCF, we designed a continuation of that program for 2022. And we are hosting 3 statewide sessions that are going to provide a very strong foundational information or basis to initiate contracting. And so that's what you're participating in today, the second of 2 statewide sessions. And like I said, we sent out the first one to everyone, but if for any reason you did not receive that, it's going to be in the chat as well. And to meet the needs of CBOs that are at those varying levels of readiness, we're also going to be hosting 15 county-specific TA sessions. So if you walk away from this session and you have like that high-level foundational information that you need to move into a county-specific session, we're hosting those sessions in Kings and Tulare, Fresno, San Joaquin and Stanislaus, and Trinity and Shasta counties. That's where we're providing that very tailored, narrowly tailored plan-specific TA. And our goals of this program, this initiative, are number one, for us to recruit CBOs that are led by and or serve people from communities that have been historically marginalized. We'll focus on identifying needs and building the knowledge needed for providers to render community support services. Secondly, we want to make sure that as a result of this initiative, that we're strengthening and building statewide capacity amongst CBOs that provide community support services. And then lastly, going back to that relationship building component that is so important. So sorry to sound reiterative, but it's very important that you all know that the plans are present in those county-specific sessions, because we want to make sure that the providers and the MCPs are building those very meaningful relationships that serve to move the work forward. And so with that being said, we can go to the next slide, in which I'm going to introduce our amazing project partners, Lucy Pagel and Jill Donnelly from Aurrera Health, who are going to deliver today's content. Lucy is going to share today's agenda and our session objectives.
Great. Thank you so much, Alexis. And thank you all for being here. Welcome. This is our second statewide session, as Alexis introduced, and we're going to talk about the first steps you should consider prior to beginning contracting with managed care plans as community supports providers. So what do you need to prepare for those initial conversations and give you confidence in talking to your managed care plans? We're going to begin with a quick overview of the CalAIM Community Supports and then dive into the standard terms and conditions, the STCs, for community supports as outlined by the Department of Healthcare Services, DHCS. Again, this is our second session. For the first session, please visit the CalAIM Links webpage with all the materials that HealthBegins and partners have developed. And also highly recommend reviewing the DHCS webpage, which has a lot of webinars pre-recorded that have taken place over the last year, and all of these materials, including the standard terms and conditions and expectations around community supports. So with that being said, we're going to dive in to everything you need to know before you start those conversations with your plans, and we'll end hopefully with a Q&A. Next slide, please. I think next slide after that. I forgot to skip the agenda slide. So our objective of this session is to really prepare you as CBOs to become community supports providers and have that confidence when you talk to your health plans and build that foundational knowledge that's needed. Before we dive into the materials, next slide, please, we want to start with a poll to understand where you all are in the contracting process. I love the emoji exercise at the beginning. A lot of CalAIM curious. I saw somebody who was like CalAIM avoidant. I understand. Hopefully after this, you'll be gung-ho about CalAIM. So poll 1, let's launch. It's where are you in the contracting process? And we'll just leave it open for about 30 seconds so we can dig into this content. Have you begun to think about contracting? Are you starting preparing materials? Are you already contracted and are just here to share your knowledge with your peers today? All right, whoever is tracking that poll, if it looks like answers have stopped rolling in, if we could share them. Looks like a majority, a lot of you are beginning to think about it and preparing materials. So this is perfect for you all as you begin to think about it. As you're preparing materials, make sure you're checking off all those standard terms and conditions requirements. Excellent. We're gonna do one quick other poll, if we can launch that, and it's a list of historically marginalized populations and underserved communities. Which of these populations represent at least 20% of the individuals your organization served in 2021? And you can go ahead and, well, it says, I think you can only have a single choice. So if multiple impact you, just choose the one that sticks out the most. And you can put into chat if there are other communities that you're not able to select in the poll. I'm guessing a lot of you cover a lot of these communities. All right, whenever you're ready to close that poll. People with limited English is coming in the chat. All right, Medi-Cal eligible children and adults. Looks like we're in the right place. Those are the folks that we want to serve with community supports. Of course, all these other populations can be part of the Medi-Cal eligible children and adults umbrella. All right, next slide, please. So I think we've already gone over, this is session 2, session 3 is happening in October. So hopefully you'll stick with us for that one as well and find session 1 on the CalAIM Links website. In our last session, we really went over Medi-Cal managed care and how CalAIM aims to improve that system, that existing system. Today's session, we're going to talk about Medi-Cal managed care plans who play a major role in the Medi-Cal system. And then Tia for our next session, where we'll go into more detail about onboarding as new community supports providers. So this is once you're in the contracting process, how you can really make sure that you onboard successfully. Next slide, please. All right. Sorry, did we miss the stages of readiness? I might have, if we go back. All right, let's just go on to the Medi-Cal side. We can move on. Okay, so Medi-Cal is California's Medicaid program, and it provides public insurance for low-income individuals and families. Medi-Cal managed care, it aims to improve care by managing cost, utilization, and quality. And DHCS, Department of Healthcare Services, the entity that operates Medi-Cal, and managed care organizations are contracted through the state to provide services to beneficiaries. We're mostly going to be talking about managed care plans, MCPs, in this context. All right, next slide. CalAIM is a multi-year initiative led by DHCS. It implements delivery system and payment reforms across Medi-Cal. It takes really a person-centered approach and builds on the successes of a previous pilot called the Whole Person Care Pilot Program to address social determinants of health and reduce health disparities. So really looking at Medi-Cal beneficiaries as a whole person with needs outside of physical and mental health needs. Next slide. Community supports are key to this CalAIM broader initiative, which is very large, very all-encompassing of the Medi-Cal program. Community supports are one piece of it. They're medically appropriate and cost-effective services that are provided in lieu of higher cost services. So they were called in lieu of services for that reason, such as hospital or skilled nursing facility admissions, discharge delays, or ED use. These services have not been traditionally covered by Medi-Cal, so this is new, this is innovative, because they do address social determinants of health and can help patients avoid preventable health issues and high-intensity service utilization. They are not Medi-Cal benefits. These are not benefits yet. Because of this, they are optional for health plans, managed care plans to offer, and they're optional for members to accept. This is an opportunity for managed care plans to contract with local providers who are experts in these community supports. So the expectation is that managed care plans are going to be contracting with you all as community-based organizations with expertise in the various community supports and expertise in your community to provide these services. I'm going to stop here for a quick poll to learn about what community supports your organization is interested in providing. So we can open that poll. There are 14 community supports. Please select whichever you are interested or have expertise in, and it can definitely be more than one. And again, leave it up to you all who can see the results flowing in when to stop the poll. All right, housing transition navigation services and housing deposits or tenancy supports. That's the bulk of it. We also have asthma remediation and sobering centers and some short-term post-hospitalization and nursing facility. No recuperative care. Oh, here we go. And home-based services, community transition, homemaker service, and environmental accessibility is also a bulk. Great. Good to know where you all are coming from in terms of expertise. So the role of community supports providers is to contract with your county's managed care plan to deliver community support. So managed care plans are in charge of community supports, but they need you as community providers to provide those supports. So that involves a contracted relationship with the managed care plan. The managed care plan works with DHCS to make sure all requirements are met in terms of community supports. Community supports providers deliver medical and social services to plan members, and again, must meet contractual requirements with the plan in terms of care models, billing, data sharing, all these things that I think sound really scary and hopefully will demystify in this session and the next session. Next slide. This is a little graphic of the relationship between DHCS managed care plans and providers to help walk through what I just said. DHCS contracts with a managed care plan in the county. In this case, there are 2 managed care plans in the county. The managed care plans determine what community supports they want to provide and contract with community-based organizations to provide those community supports. So in this example, MCP1 has community provider A and B. They each offer different community supports. MCP2 does also contract with community provider A to offer housing community support, but they also have a different provider, C, who provides medically tailored meals. The other MCP is not offering medically tailored meals. So this is all to demonstrate community supports are really optional for the health plans. Even in the same county, health plans could offer different community supports. So as you become a community supports provider and talk to your managed care plans, you can expect that things may look different managed care plan to managed care plan. All right, here we get into the fun stuff, the standard terms and conditions. And this is how you can prepare to become a community supports provider and know what you need to do. Next slide. So the Department of Healthcare Services released these standard terms and conditions, these STCs, for community supports providers, and the DHCS released them, and then managed care plans would ask you to comply with those standards, terms, and conditions. They're on the DHCS website for your reference. Again, DHCS develops standard for providers contracting with managed care plans that should be built into provider plan community supports contracts. So your health plan would build these standard terms and conditions into your contracts with them when you're looking to contract to be a community support provider. Your managed care plan that you're working with is going to review your ability to meet those STC requirements during contracting and may review your service offerings to ensure that you are complying with the STCs. The main elements of the standard terms conditions are listed on the slide. It's what your services are, the requirements for offering those services, the requirements around quality and oversight, data sharing, payment, all of that fun stuff. Provider responsibilities. So these are the key provider responsibilities that are covered under the STCs. For providers who are just getting started with contracting and are new to this whole Medi-Cal world, it's important to begin reviewing these responsibilities and thinking about how you can document your organization's practices and demonstrate readiness and ability to comply with these standard terms and conditions. Your responsibilities in terms of outreach and engagement. You must be ready to meet specific standards around the initial outreach to beneficiaries and continuing engagement. The initial outreach must be conducted within 24 hours of member referral. So the health plan will refer beneficiaries to their community supports providers, and it's the community supports provider's responsibility to then outreach to that member upon 24 hours upon being referred that member. Providers must be responsive to outreach from members, including maintaining a phone line, setting up an appropriate staffing to monitor voicemail and answer calls. We know this can be, difficult for smaller CBOs, so it's something to consider how you're going to make sure that you're responsive to members. Providers must also be prepared to coordinate with other providers that are on the member's care team. So community supports is a piece of the CalAIM puzzle that's closely linked to enhanced care management. Folks who are receiving the enhanced care management benefit often will be connected to community supports. So as a community supports provider, it's important that you're able to work with a beneficiary's entire care team. And I'm going to pause right there. I see a lot of questions coming in. Folks monitoring them, are there any we should answer now, or should we keep on going through?
I think we can keep going, Lucy. There are a lot of great questions, and I think at least a few of them we haven't touched on yet in the chat will get addressed in future slides.
Excellent. I just saw a fun chat going on and I felt left out, but we'll continue with the slides. So community supports provider responsibilities regarding staffing. Staffing is hard these days. Workforce is difficult these days, but providers must maintain adequate staffing to provide services to those beneficiaries the health plan refers to the provider to provide community supports. This means that the staffing must facilitate timely, high quality service delivery to beneficiaries who are referred to them for community supports, and you must be able to accept and act upon referrals. So that's an important note. Next slide. For data sharing and reporting, providers and managed care plans both have data sharing responsibilities. Those are outlined in the STCs, the standard terms and conditions. As part of the referral process, the MCP responsibility is to provide community supports providers with billing data, health plan policies and procedures, and other information needed for you as a provider to submit invoices. And they're also required to share appropriate demographic, administrative, clinical, social service information so that you can confirm the eligibility and effectively provide the service to the beneficiary. You as a provider also have data sharing responsibility. You must share your claims and invoices with the managed care plans, along with any other data the managed care plan requests that they need to enable monitoring and oversight. So the managed care plan is held responsible by DHCS for oversight and monitoring. And so then as a provider for the managed care plan, you have to be able to give them the data they need to meet that requirement for the state. Claims and invoicing. So this is something we hear a lot of concern from smaller community providers about being able to make claims and invoicing requirements. So the STCs outline requirements for both claims and invoicing. Claims are preferred. That's where what MCPs want, that's what the state wants, but there is an understanding that some CBOs aren't yet set up to submit claims. And those are claims with 837 files. But if you don't have the infrastructure to submit 837 claims, you are able to invoice the MCP. The managed care plan is responsible for providing you with an invoicing template and a process for billing. So that's up to the managed care plan to help you understand what the process is for submitting a claim or an invoice. It should be pretty standard between managed care plans because there is DHCS guidance on that, but there might be small differences between plans. And I just want you all to take away from this that though claims are preferred, it is not a condition of contracting with an MCP. If you do not have the infrastructure to file a claim, you can still be a community supports provider. All right, service delivery. So the last point I want to share from the STCs before passing it on to my colleague to dive into even more fun stuff, providers must deliver community support services according to service definitions. So each community support has comprehensive service definitions that must be followed. I really recommend the community supports policy guide for diving into those. You as a provider are going to be reimbursed only for the services that are authorized by the managed care plan. So your managed care plan will have services that they have told the state they're authorizing. That's what you can be reimbursed for. This means if a member requests a service that's not authorized, you should send the request to the managed care plan to have it be authorized by them. It's really important that you have a clear understanding of your health plan's authorization process. This may vary from plan to plan and is something that as this community supports have rolled out, we know that it's been helpful if you're very clear on your health plan's process. All right, now that we cover the basics of what's expected in the standard terms and conditions, we're gonna dive into how, as potential community supports providers, you can begin outreach to managed care plans. But before that, we wanna pause for a quick Q&A. And this is the knowledge check. These are the items on the slide that I hope you got over my really quick presentation just now, but I do want to pause looking at my colleagues to see if there's any unanswered questions or something we can expand upon before moving on.
So Lucy, in reviewing the chat, it looks as though Jill was incredibly fast with her chat responses. And so Jill, is there anything that you missed? I see that you got to the questions from Patricia, Katie, Anna. Let's see. I'm not sure if you got to the one from Christina that states, let's see, I work with clients that already have contracts with MCOs, and the consistent feedback we received is that the MCOs are unprepared to be helpful with CalAIM initiatives. They don't seem to be able to answer basic questions. Any feedback or advice?
Yeah, it's a tough one. I mean, we are going to talk in this next section a bit about, you know, how to work with the managed care plans a bit. And we're going to talk mostly about how to get into the contracting process and the readiness process. But if they already have contracts and they're having trouble, that's kind of a different thing. Most health plans should have, they might be called practice transformation specialists, or they might be program specialists or program managers who are assigned to each contracted CBO. Different plans have different models, but I would advise them to work through their contacts at the health plan. I would also add many of the health plans have developed their own support materials. So we've seen a lot of billing guides. We've seen a fair number of program guides or program descriptions, that kind of thing, how to work with that managed care plan. So it might be a matter of requesting, you know, specific documentation they may have available to CBOs. But that is concerning. It is their job to support CBOs they have contracted in their ECM or community supports network.
And then I'll respond as well to questions that we received from Aaron in America. So the question is, are you seeing plans contracting with their local health departments or other city or county agencies to offer community support services or to serve as a lead entity to then subcontract with CBOs? And so the answer to that is yes. And we provided content in the first statewide session that we have dropped in the chat for everyone that actually has an entire section on direct versus indirect contracting and the types of entities that MCPs are contracting with that a provider can then subcontract to. And they would still need to meet those same standard terms and conditions that are outlined by DHCS. However, there is less administrative burden on the provider themselves if they're not yet ready to move into direct contracting with an MCP. And so what I'll do is go ahead and relink that text, those links in the chat so that way you can have access to those materials. And so just as a reminder, the content that's being dropped in the chat is a recording of the session and the actual materials themselves. So that way you can use the materials as a guide as you're going through that presentation. And so super happy that we already have that content outlined for you all.
And just to go off of what you're saying, Alexis, so there are some plans that have authorized a hub model. So there are, the whole person care pilots that we referred to earlier have had a lot of experience. They're county run pilots that have become community supports providers, those counties, and some of them had established relationships with CBOs. So they acted as the hub that the health plan contracted with, and the CBOs contracted directly with the county. I would not say this model is something that we're seeing used widely at this point. So I would say, always having the initial conversation with your health plan, it is important to understand what the health plan is practicing in terms of whether they're having a hub model or they're directly contracting with CBOs. But there's content in our first slide deck about that. Yes, the youth population is going live later. So health plans may not be ready, and that's for enhanced care management. So we're talking about community supports, which are available, were available starting January 1st, 2022, depending on if the plans elected to take them up, as it is optional for the plan.
But worth mentioning that there are kids eligible under some of the existing live ECM populations.
Definitely. And with that, I think we have a little pause in questions so we can switch to you, Jill, to dig us deeper into this community supports maze.
Okay, great. And these are great questions, so please keep them coming. We'll, if we don't get to them during the presentation, we can always follow up afterward. So we're gonna try to break down the process of engaging with managed care plans into a few steps over the next section. And it sounds like a lot of you are in the sort of thinking about it phase. So hopefully this will be helpful as you're thinking about whether and how to move forward. So go to the next slide. Okay, so the first step in this process is really to assess internal readiness to become a community supports provider. And this could include reviewing service definitions in the community support policy guide, which I linked a little earlier, but it's also available on the DHCS main website, and identifying the supports your organization is prepared to offer, as well as reviewing the standard terms and conditions we just discussed and begin identifying how your organization can meet these requirements. You can also use the HealthBegins Readiness Assessment, which is great. It's an optional tool that breaks down the key elements, and I think we're going to share it in the chat. Next step is to start talking to the managed care plans in your area. If this is new to you and you're not sure which managed care plans operate in your region, we can send out a link to share kind of who's where. After assessing, what you can offer, that's kind of an assessment that's really helpful to take to the managed care plans. And then once you reach out to the managed care plans and confirm that they're interested in adding you to your network, you can start to learn a little more about the plan-specific requirements. So, just to step back a moment, all of the plans have a set of requirements that are outlined in the policy guides and in the MCP contract language, which I think Alexis has already shared. But so there's some broad standardization, but there's quite a bit of plan-specific information you might need to know around documentation, around billing, and around policies and procedures. So we can go to the next step. Okay, so then we enter the information gathering and the provider application process. Many of the plans are using a standardized application tool. If any of you are familiar with the Health Homes application process, it's very, very similar. This usually includes all of your organizational contact details, including who they should work with for contracting, and the services you're hoping to offer as a community supports provider, as well as information on P&Ps. So we've got some of these domains listed here. Some plans will ask for you to link a bunch of documents, maybe your program description, it might be your staffing model, it might be other P&Ps that you have or need to develop. Next slide. After you have access to your plan's provider application, you'll want to be ready to gather all the information that plan needs. So again, org charts, background info on your experience in the community, any P&Ps, and we'll talk a little bit more about Npis in a moment. Oh, great. Thanks for throwing those links in there. Okay, and then you'll move into the contracting portion of the process. You can expect that once you submit your application, that there may be some back and forth with the health plan. Many of them will develop some sort of gap filling plan and process and help you work on filling those gaps prior to go live. You'll usually simultaneously, you'll start looking at the contract itself, making sure you can meet all of the requirements in the contract, that you understand all the requirements in the contract, which sometimes involves additional documentation if there's a model of care involved, and of course, rate negotiations, and then finalizing that contract. So this is a fairly long process. Typically, putting together an application can take several weeks. Gap filling plan and process can take several more weeks, and finalizing contracts can take anywhere, depending on kind of legal back and forth, from a few weeks to several months. So it can be, I would expect a kind of a longer on-ramp. If you are a government organization, sometimes that's even longer. Counties and other government entities can take a long time. And I see the question, what's the gap filling process? So it's different for every plan, but usually what it's going to be is they're going to take that tool that you submitted as part of your application and mark it up and say, hey, when we asked you to describe your service model, it met most of our requirements, but there were 2 requirements it didn't meet. So why don't you go back and make some modifications to your P&Ps or your program description so that it meets our requirements. So it's usually some kind of document exchange. Occasionally there's a need to bring on a new system or some other some other readiness to meet the application requirements. It's usually a back and forth with how do you negotiate rates? That's a great question. I'm not sure we can get into that on this call. Some of it's definitely a private conversation between health plans and providers. Plans will usually come to the table with proposed rates. Often those rates are based on whatever indication. There are I'm blanking on the term. There are suggested rates. That's not the right term. Lucy or Kathleen, feel free to jump in. There are community supports rate. The state, there's some guidance that the state has proposed for community supports. It's non-binding is the key. So the health plans all get to determine what rates they want to propose, but that guidance is there to kind of give you a starting place. So you have an idea going in. Thank you so much for posting that. Non-binding. Thanks, Lucy.
And Jill, I just wanted to hop in really, really fast to let everyone know that when We sent out the registration links for the session, that we also included the link to the CBO Readiness Assessment. And we explained that it was, just so vitally important for us to receive feedback on the areas of learning gaps that CBOs are experiencing. So that way, as we build out the county-specific sessions, if you are in the counties that we are servicing, that we will be able to incorporate that into the curriculum. And so negotiations is something that we have heard feedback on. So I'm just going to go ahead and redrop that link inside of the chat, so that way we can go ahead and just hear from the CBOs directly, where you are within your contracting readiness and the topics that you need support with. So I just wanted to let everyone know that I'm going to drop that link in the chat for you all if you have not completed it. And if you have, thank you so much for all of that feedback, because it's really important for us to hear from you exactly what topics need to be incorporated into the curriculum.
And Anne, I see your question that some MCPs are asking providers to sign NDAs. To my knowledge, that's not common. That's the first I've heard of that happening, but they are meant to be private, and there are some antitrust considerations if organizations sort of are formally trying to negotiate rates together. So it is one of those things plans discourage. Plans are also not allowed to set rates together, so they all do have somewhat different rate structures and rates themselves. And maybe I should say one more thing about the rate structures. So there are some community supports that are very likely to just be fee for service from the plans. There are others that we see plans doing kind of a one-time sum to support the member. There are still others that may be a capitated rate, something that's monthly and ongoing. So they're all going to structure these things somewhat differently. All right. Next slide. All right, so we're going to do a little knowledge check. So when preparing to contract, providers should assess internal readiness, initiate discussions with the MCPs in your area, gather and compile the documentation you need to fill out the managed care plan's application, and then anticipate going through a gap filling process and the contract and rate negotiations. Any other questions on that process? Yeah, it's a great question. How are CBOs with multi-county footprints advised to approach contracts and rate negotiations? So I think it depends whether you are dealing with one managed care plan across multiple regions or multiple plans. If it's multiple plans, you're likely looking at separate negotiations and separate rates, quite honestly. If it is the same plan that's operating in multiple counties, like some of the local initiatives, are covering multiple counties in Southern California and in Northern California, or if it's one of the commercial plans that spans multi-counties, it would be typical to have one contract to cover multiple counties with a singular plan. The rates might not be the same. The rates might not be the same in county by county, even with the same plan. Many plans develop different rates based on local costs, but you could do it under one contract if it's the same plan. Yeah, and again, I think we covered, but NDAs are not typical. It doesn't mean it's not happening or it's against the rules, but it's not something I've heard of before. All right, so any other questions before we move forward? We're going to start talking about NPIs. Heard some challenges around referral volume post-contract. So I'd be really curious, Erin, if you want to come off mute, whether the referral volume issues are that they're getting too many referrals or too few.
Hi, this is Erin. Thanks so much for looking at the question. We've been hearing about too few. So they enter a contract and then very low volume.
Yeah, so I think, so we've definitely heard about it in both directions. And I think that it's very challenging for managed care plans to kind of right size the referrals or the target list to the capacity of the provider. Sometimes that's complicated by the fact that some providers are contracting with multiple plans. So if you have the capacity to serve 100 members, but you're working with 3 plans, it really reduces how many you can take from each plan. They don't always, there's no way for them to communicate about what volume they're giving you. So I think that's a challenge. So we've definitely heard, hey, we're getting way too many people. We don't have the staffing yet, or we don't have the infrastructure to support that volume. The other end of that spectrum, what you're talking about is, hey, we got the contract in place and now we're just waiting. And maybe we hired and we bought a new cloud-based data system and, we got everyone trained on billing and we're just waiting for these referrals to come in. So we are hearing that. I think, especially with community supports, it's a real challenge. Many managed care plans don't have the algorithms built yet to find these members in their populations to refer them to providers. They may not have other ways of indicating, of flagging and sending on these members to community providers. One of the things we've seen some providers do is start referring their members back to the plan. And saying, hey, we serve this population today. We know their managed care assignment. We're going to refer them back because we think they're eligible for this community support. And plans are used to receiving those lists. To start receiving payment, they would need to authorize that service. But that sort of reverse referral process is one way to kind of handle that. Or to set up other referral relationships with hospitals or with other community providers or CBOs who may have more visibility into who's eligible for the community support. But it's a real challenge. And I see, did we address what is the gap filling plan? I think we did. So gap filling, again, is that back and forth with the health plan after you've filled out the application. And it's usually a document exchange. It's, hey, you forgot to attach document C4. Can you send that back? Or you sent me an org chart, but half of it's blank. Can you fill that in? It's some kind of document exchange, unless there's something really structural that's not in place. And some plans will do on-site reviews. We'll kind of come and make sure everything's as expected, but for the most part, applications are through email. These are great questions. All right, why don't we keep going? We'll talk a bit about NPIs. So I think we can go to the next slide. The National Provider Identifier is a numeric identifier assigned to each healthcare provider by CMS. NPI can be used on claims transactions for healthcare billing and reimbursement. In order to be reimbursed for community supports, providers must have an NPI. So let's talk about who needs an NPI. We can go to the next slide. It's everyone who wants to be involved. All community supports providers and organizations that have a contract with a managed care plan that submit claims to the managed care plan for reimbursement must have an NPI. Employees and subcontractors of ECM and community supports providers organizations are encouraged to obtain an NPI, but they're not required at this time. So again, it's just at the organizational level. If your organization already has an NPI, you just need to check that your NPI profile is up to date. So we know that a lot of CBOs have not participated in Medi-Cal in the past, and getting an NPI is going to be a new thing. I think the big takeaway here is that it's not too bad. They've really simplified the process over the past couple of years to make it a lot easier to navigate. It usually takes about 20 to 30 minutes. You can apply online or by mail through the CMS NPI application update form page. And there is a really useful step-by-step guide to the NPI application process that DHCS has put together. It's got a lot of great detail in there, pretty easy to navigate. State discussions to remove the NPI. I'm not aware of that. I believe the NPI is continuing to be required. We can double check on that, but that's not something I've heard. Oh, yeah, it's a great question. Do CBOs have a data submission requirement? And if so, what interface would they use? So let me answer those separately. The first question is there a data submission requirement? Absolutely. Most CBOs are going to be required to either submit invoices or claims. And a lot of folks, you can send in paper claims, but a lot of folks are using some kind of electronic submission, maybe an 837, maybe working through a clearinghouse or some other mechanism. The other type of data submission that is definite would be quarterly reporting, or maybe monthly reporting, depending on the health plan's requirement, the individual health plan. And each of the health plans is going to have kind of a different way to do that. They might have a platform you can sign into and enter the information right in there. They might have some other kind of platform where you can upload a spreadsheet or download a spreadsheet. eClinicalWorks, I'm not sure. It would depend on the health plan you're working with. And then there are other types of data exchange that I can't guarantee would be required, but they're likely to be required. So something, there might be instances where some kinds of consent documentation is needed, or a care plan documentation is needed. Oh, okay, what's this next? Is there a care plan with that upload or just a cost line item? So possible that there would be a care plan requirement. Again, it depends on the health plan and what they're requiring. There certainly would be a claim requirement. And the invoice, so the state has said if you're not able to submit claims, health plans have to accept invoices, but the invoices are very structured and they essentially capture all of the claim information. So that is a guaranteed yes, would need to be submitted. Okay. And I think I already said this, but applying for an NPI has gotten so much easier in the past few years. The link is there, the guide is there. I mean, I say it's easy, but I'm sure once you get into it, there's always going to be a hiccup, but we haven't heard organizations getting stuck on this step. This has gone very smoothly during this implementation. Okay, we can go to the next slide, and I think we've got a poll. Okay, so which of these takeaways has been most helpful to you? Understanding the context of CalAIM and the relevant background, the standard terms and conditions for provider contracting, how you can get in touch with your managed care plan and get basic information about contracting, and the NPI info. We'll give everyone a moment. And Anna, it's a great question. If a CBO works in a county with multiple MCPs and wants to contract with more than one, will they have a way? They will have to track submit claims and report for each, and the answer is yes. Hopefully it's not entirely different. There has been a real effort to standardize, but what we've heard is it's not quite as standardized as we'd like to see. There are differences. And the poll takeaways, it sounds like understanding the context of CalAIM was by far the most useful. That's great to hear. hearing more about the standard terms and conditions and how you can get in touch with your MCPs has been useful. NPI is less than useful, but we get it. It's not that exciting. It's not the fun stuff anyway. All right, and with that, I'll hand it back to Lucy.
Great, thanks, Jill. So our session 2 takeaways, following the poll results, we hope you understand the context of CalAIM and community supports, understand how it all fits into Medi-Cal and how CalAIM is really focused on improving the Medi-Cal system, and community supports is honestly one smaller piece of that puzzle. It's a huge CalAIM puzzle of trying to improve beneficiary care in California. But it's a very important, very innovative piece of that puzzle. We wanted you to understand the standard terms and conditions, understand that these are developed by DHCS and are something that the managed care plans are building into contracts to really ensure that as a CBO, you understand all the requirements, you understand that MCPs have requirements to DHCS as well, and that contracts with managed care plans do have standardization across the state. We wanted you to understand how to contact your county managed care plans and when to do so, and understanding what is going to be required of you before getting into those conversations with managed care plans. And number 4 is in the same vein, understanding what information you need to come prepared to present to your managed care plan, and spending some time organizing and thinking about that ahead of reaching out to your managed care plan to demonstrate interest in the community support. Of course, kind of check in your county to see if the managed care plans in your county are offering community support that is in line with your expertise. There is a resource on the DHCS website that shows which managed care plans are operationalizing which community supports. So I definitely would start there. I know that wasn't in this presentation, but it's been in previous presentations. And again, not as cool, but how to apply for an NPI, it's important. So that's what we hope you got from session 2, and session 3 will build off of all of this and really go into gap filling. We'll really pay attention to the questions you had today and build that content into session 3. We want session 3 to be really build off of this one and answer your questions and be responsive to where you are in the contracting process. So I will, I think, pause there and turn it back to Alexis, but let's see the next slide and we can tell me if I'm wrong. Okay, I went over this. We're going to talk about filling gaps, more about contracting discussions, and build as much as we can from your questions today into session 3, which is on October 6th. Final question.
Yeah, thank you so much, Lucy. And I do see that we do have one question regarding if we're going to be able to have content on PATH and how PATH can support CBOs to be successful with the admin aspects of this work. And I think that, Lucy, would it be okay to briefly discuss the cited application?
Yeah, I can briefly point to it. So PATH has several different components. The component that's probably most relevant to you and just got released is the PATH cited application. I cannot remember what cited stands for right now if Jill wants to touch in, but it's really a pot of money to help with infrastructure and development, to really give you the funding you need to build your competencies to become a community supports provider. Cited funds are available to CBOs who are contracted with or in the contracting negotiation process with MCPs. Those of you who are not contracted but are headed that way with your MCP would need a letter. Well, everybody needs a letter from the MCP, but you need a letter saying, yep, we're on route to be a contracted community supports provider. PATH funds, there are 5 phases of funding. The first is open now. And it's 18-month funding, funding buckets. And this current funding that is open, that just opened, is available retrospectively to January 1st, 2022, if you're already a contracted provider and have already spent funds on building up infrastructure to be a community supports provider. So I highly recommend, this was a capacity and infrastructure transition, expansion and development. Thank you, Jill. It was super simple. I'm sorry I forgot it. But I really highly recommend reviewing these materials that have been posted in the slides. Really recommend understanding if you're eligible for PATH, or reviewing reviewing the cited bucket to see if it's something that if you were to have access to that those funds as a community supports provider, if that would make it easier for you to be a provider and make it more palatable for you to go down this path. Of course, understanding that you can't access the funds until you're on the path to being contracted with an MCP. All right. Yep. Go ahead, Jill.
I think that, and there is so much new information out there about PATH. It's really an exciting amount of opportunity for providers and counties to get some funding to develop some of this infrastructure. If you are an organization that's involved in the justice-involved population, there's a separate pot of money under PATH that would be available to you as well. And I think there's another question about NPIs for Medi-Cal services at the employee level. That's something I don't know. I don't believe, no, I believe it's almost all organizational, but we could check on that. Certainly for community supports, employees do not need an NPI, only the organization. And Carlina's put a lot of great information in the chat about PATH. It is a big pot of money for people who are providing direct services. So there are also dollars there for regional collaboratives, for former whole person care counties to pay for former services and for the transition. So lots of good information there.
And I think importantly, what we didn't mention is PATH money is directly for providers. It doesn't go to the health plans. It goes to you as providers directly. So it's not a trickle down for the health plan. There is a bucket of money for the health plans called the incentive payment program, but this is really targeted at you all as CBOs.
We should mention, to be eligible for PATH cited dollars, you do have to be contracted or in the process of contracting with a managed care plan. So it's not, unfortunately, it's not available to get you to the point where you could contract. It's for those who are kind of in the mix, are already on the way or contracted with managed care plans for community supports or ECM. I don't know the dollar amount off the top of my head for the justice involved PATH dollars, but certainly something we could look up. It's probably also in one of the links that's already been shared. It is a separate pot of money, and some of it's still, the details are still being worked out. It's yeah, it's not something I know off the top of my head.
All right, and thank you so much, Jill and Lucy. I believe that we were able to address all of the questions. And yeah, I think we're able to address all of the questions. And so because we understand that hearing this information for the first time and sometimes even the second time is very challenging to process. And we're trying to really demystify and deconstruct, CalAIM specifically within the context of community supports. We've included all of the links that were included, posted in the chat today inside of the slide deck materials that were provided in this chat. And so if you have that slide deck, we'll post it one final time, just in case you missed it the multiple times that we posted it. So that way you can make sure you just have access to all of those really valuable resources that are very informative. But most importantly, our next steps are very, very, very important. And so as I mentioned, a link to the slide deck is included in the chat so that way you can have access to everything that was discussed today. We really want to just re-emphasize that completing that CBO Readiness Assessment is very important, because that's one of the tools that we use to, number one, assess your organization's level of readiness to determine whether you're a better fit for these foundational sessions, or if you need to get integrated into a county specific session because you are at a higher level of readiness. And we've also included an additional needs survey inside of the chat for you as well. That survey is going to, number one, let us know what topics you need support with. If you do have a higher level of contracting readiness, we will be able to utilize that information to say, hey, these are the specific topics that you need support with moving into like whichever stage of contracting you're in. And we've even been receiving questions pertaining to implementation. So that readiness assessment and that additional needs survey are both, two very important tools that we use to make sure that we're supporting CBOs in the capacity that you need to be supported. And lastly, we understand that the conversation does not end today. We are going to have that third and final foundational session taking place on October 6th. And so we want to make sure that we're redirecting everyone to the CalAIM Links website so that way you can register for that session. But if you have any questions, our email address is inside of that deck. So you can contact us at calaim@healthbegins.org with any additional questions that you have that were not addressed today. And I thank you so much, Melissa, for posting all of those links in the chat for us so that way you can have access to everything that you need. And we're going to close out today's conversation. And so if we move to the next slide, I just wanted to give a very special thank you to our entire project team. And so today's presentation was developed and presented by our team at Aurrera Health. Until we move to the next slide, we'll see that that consisted of Kathleen Kane, who contributed to content development, Lucy and Jill, who so wonderfully facilitated. And if we move to the next slide, we also received support from Transform Health. And then finally, our wonderful team here at HealthBegins. And this project is being evaluated finally by Beth Siegel at Mount Auburn Associates to make sure that we are delivering this program in a way that is going to support CBOs in a very tangible and impactful way. So thank you all so incredibly much for joining us today. If you have any additional questions, please email us, and a link to the resources has been provided in the chat and will also be uploaded to the CalAIM Links website. So thank you, everyone, and have a wonderful rest of your afternoons.